Thank you, Richard, and good afternoon, everybody. So I've got, I think, 10-15 minutes to set the scene locally and set out our ambition for the South East. So I guess I've got three main points that I would like to share. In terms of point two, I'll just do a quick summary of the work we've done to date collaboratively, so with many of the people on the call and others that are not on the call, and then set out future steps on continuing on this call and on this theme. But in terms of point one, what we've tried really hard to do in most of our calls and webinars is to try and bring to the fore the patient, the service user voice or the carer's voice. And we didn't have a story today to start the webinar, and something that is entitled "How do we optimize patient flow and remove barriers to discharge" might feel quite dissociated from human beings and the people who actually use or deliver the services. So I just wanted to share a story and really bring that voice back into the room today before we move into something that feels very much like in a pre-pandemic world would have involved a lot of coloured post-its on the walls and a lot of charts and flow charts and arrows and words like removing bottlenecks and not necessarily refocusing on the people at the centre. So courtesy of my children, who have had a few hospital stays between them, I know what it feels like to be the parent or the carer in a hospital environment where, even as an NHS professional and knowing the system from the inside, that feeling of helplessness and powerlessness and actually being in a system, in a place that is bigger than what you can control, where you're being forced to get up at a certain time and the lights are switched on, where access to the toilet or the shower block. My daughter at the time, 3.5 years old, had a week stay on a paediatric ward, and there were 2 toilet and 1 shower cubicles for an entire ward. So I can tell you that the time I chose to go and use the shower was generally close to midnight when she was asleep, and I knew there wouldn't be a queue. But that kind of environment feels really alien and quite scary and different from home. And obviously for a mental health inpatient environment, the ability to be there with your loved one is even more so restricted than it is in an acute inpatient ward. So the story I wanted to share was one of my friends who, in her mid to late 30s, through a series of life events, became quite morbidly anorexic. And that resulted in 4 separate inpatient stays over the course of 4 to 5 years. So just in itself, you know, I think the recurrence of being in and out of the system shows that the transitions, the flow in and out wasn't quite managed in a way that it supported her to be back in control and be able to manage condition and anxiety in a way that was helpful. So stays 1, 2 and 4 were in a local hospital close to home. Stay number 3 was in London, and London is 2 to 3 hours drive or train journey from home. So in terms of visiting and the ability for the children to go and see her, that was obviously quite limited. I remember going there a couple of days after she'd been admitted and bringing a whole pack worth of stuff, because she was still in an observation ward where, well, in an observation room where there was the bare minimum. She didn't have access to toilet or shower or even a wash hand basin. Everything had to be very carefully monitored and locked to make sure that she was as safe as possible. So I had baby wipes and, you know, some kind of spray and dry shampoo and hand cream, anything that I thought could make, and anything that she'd requested to try and retain some kind of dignity while she was quite acutely poorly. So she stayed there for 9 months, which was a really, really long time. And then there was a fourth inpatient stay. So whilst over the course of the 9 months she got better, at the time where she got discharged back home in the care of the community, things didn't go quite so well. And actually a fourth inpatient stay started with an overdose, going through an acute, blue lighted A&E ward, stomach pumping, and then several assessments as to whether she was stable enough to go back to an eating disorder service or whether she needed a bit more acute psychiatric care before she could be moved to the eating disorder service. And every time she got a bit worse, every time she learned something more about how she could hide from the ward and the clinicians and her family illness, and how she could push that and control that a bit further. And that feeling of helplessness and powerlessness, I had it as a friend and as a visitor, and obviously for her family it was really, really hard. So that principle of optimizing flow, it's not just a process, it's about the people at the centre, it's about how we manage the transition, how we support the clinicians who also might see people coming back recurrently, and help them transfer back home in the community as safely as possible, and limit as much as possible their inpatient stay so that it is efficient, but it doesn't bring about some of the adverse effect that I saw in her in becoming a better eating disorder patient. So I wanted to start there. And in terms of setting the scene for the South East, we've been doing quite a lot of work already, and it's been shrunk down in different work streams. So we've been doing a lot of work around the independent sector provision and identifying appropriate, inappropriate out of area placements. But beyond that, again, it's about making sure that the care given to people is as good as it can possibly be, and the transition between the different care providers, whether NHS, whether independent sector, charitable sector, etc., is as good as possible. Then we've had a second piece of work which is coming to an end around identifying barriers to discharge. And again, that has brought to the table colleagues from local authority, from social care, from housing, and a number of partners without whom it wouldn't be possible to deliver adequate mental health services. And then the final piece of work that we've been doing is relating to mapping the pathway of a mental health patient through an acute physical health setting. And again, how those transition and handling point, and how the different clinical teams work together. So I think the challenges, we've worked through a lot of them in terms of the demand, the lack of bed, the difficult points in terms of transitions. And we've had a number of partners coming through and coming around the table to help and discuss some innovative practices and some interventions that have worked and they wanted to share. And we should just build on this. So the work for the future that we're hoping to deliver, and the ambition is to bring all of these pieces of work together. We have some requirements, I guess, from national colleagues, because some of the enablers are the additional funding that has been made available, and also keeping track of the data, because as we look at the data, obviously we can see how we're progressing and how well we might be doing towards achieving our goals. But these are really the enablers. They're not the be all and end all. They're the vehicle to achieving our ambition, which is to deliver safe and high quality care, and really work on that continuity of care across all partners in a joined up approach. So I know that we've had we've had a late change in speakers today, as someone had to pull out of the day because of a CQC visit. So Daniela and Sarah have done a lot of work on trying to reorganise the hour or the next 90 minutes so that it's as useful and helpful as possible. But some of the key words to me for today are that joined up approach to care, working across agencies and with partners, and keeping our patients, service users, carers, all of us really at the centre. So the big buzzword around optimising flow, again, they're really here to help, because what we're doing is really looking at the best possible care for the people who live across the South East. I think, Richard, can we go back to the agenda, please, Jane? Because having talked about collaboration and joined up work, I think that's probably a good transition to go across to Hayden and Sonia to come and tell us a bit more about your work across Portsmouth.
Yeah, certainly. Can everybody hear me? Yep. Yeah. So, yeah, let me just give a little bit of background. So my name is Hayden Gins. I'm Assistant Director for Children's Services in Portsmouth, and I've got a share post from the CCG and the local authority. And my colleague, Sonia King. Sonia, do you want to introduce yourself?
Certainly. Hello, my name is Sonia King. I'm the Service and Quality Manager for the CAM service in Portsmouth. I am part of the Solent wider NHS Trust, and there is also a CAM service in Southampton, which is, again, separate commissioning, but very similar themes that we are working on.
So if I just, I think, Daniela, I think you're going to kind of do the slides for us. If I just kind of go through a little bit of kind of context and background for a couple of slides, I'll fly through this fairly quickly, and then we'll land on Sonia's part, who can talk with much more authority than I can, particularly around the kind of patient flows and particularly around tier 4 beds. So just in terms of a bit of background, so in Portsmouth we've got quite an integrated model of public service delivery, but particularly around the mental health agenda. We've got a number of shared posts between the CCG, the local authority, and some NHS around all sorts of work around early help, around safeguarding, around education services, and you know, we're very proud of our kind of partnership working across the public service children's system in the city. One of the things that we've been doing over the last year, actually, during the pandemic, bizarrely, was to refresh our strategic plan for children in the city. So we've got just shy of 50,000 children in the city, 0 to 18. And we have a children's trust partnership which sits under the Health and Wellbeing Board, and one of the things that we've been doing over the last year is refreshing what we call our SEMH, so borrowing the language from the Special Educational Needs and Disabilities agenda to move us beyond just a kind of clinical model of mental health to really think about emotional wellbeing for children as well as mental health. So our partnership is extensive, and we do very much a lot of kind of close working, particularly across health services, local authority service, but also the police and the voluntary sector as well. And we talk a lot about integration. So shared services, multidisciplinary services. We've got a number of CAMS professionals that are not only based within the CAMS service within the city, but also you'll often see CAMS workers pop up in all sorts of wonderful places. So in our children's social care function, our care leavers, our work around early help and early intervention. We've got the MHSTs, the mental health support teams in schools. So we very much have a close partnership working between local authority services and CAMS services in the city. Daniela, do please move us on. So we've got a shared strategy, our ACMH strategy for the city, and we've based it around the Thrive model, which I think many of you will be familiar with, which is essentially a kind of tiered model around understanding mental health concern and also what the kind of public service response to emerging and clear mental health need. Our SCMH strategy has a range of measurable outcomes, so not only the the traditional kind of waiting times and the treatment outcomes from CAM services, but a much broader set of kind of proxy and direct indicators around emotional well-being, everything from exclusions from school, which is a very significant issue in our city, and attendance at school is also a very significant issue, but a range of other kind of indicators which give us some kind of sense around emotional health and well-being of children and indeed their families. And we're very big on family-based practice as well, not just services directed at children, but services directed at families as well. Daniela, next slide, please. Under that strategy, we've got 10 work streams. And what often surprises people when we talk about our social and emotional mental health is that CAMS is it's a vital part, but it's only a part of our strategy. So, for example, we spent a lot of time recently talking about early attachment. How do we work through midwifery, through health visiting, through early year settings to promote early attachment? Because we know that in terms of good, effective demand management of mental health concerns, that actually early attachment to caregivers is a really important part of the story. We structured our work streams broadly around that kind of Thrive model in terms of how do you prevent poor mental health all the way through to how do we enable easy access to support and services, including recently commissioning a digital service through a provider called Kooth, which has been taken up really, really well by children and young people in the city. So we've got quite a comprehensive strategy with a number of work streams. It's very much seen as a multi-agency responsibility. So we talk a lot about, just as I often kind of compare this world to a world that I've spent most of my career in, which is safeguarding children. I think we've absolutely nailed that in terms of everybody understanding that they've got responsibilities around safeguarding children. We now push the language of mental health is everybody's business. Everybody that works with children in the city, which is somewhere near 3,000 professionals across the system, have a responsibility for promoting and or responding to child mental health. Next slide, please. We've got a set of kind of shared principles and values. I won't read them all out for you without point about everybody's business. We talk a lot about relationships and relational practice in the city, and we're a city that's pursuing restorative practice in terms of really encouraging strong relationships within families, but also between families and paid professionals and volunteers who work with children and families. We also talk a lot about trauma, being trauma-informed and attachment aware. So I've put those in red for you. We do a lot of work around trauma, and not only the trauma that children experience, but also the trauma that parents experience and how that can impact on the capacity for parents to care for their children and to promote good education, health and care outcomes for children. So we've done a lot of work on understanding the impact of trauma, that relationship with attachment and that relationship with child welfare and wellbeing. Next slide, please, Daniela. So just unfolding the Thrive model, the kind of level of need in terms of using the Thrive language around getting advice, getting help, getting more help and getting risk support. And we'll focus a little bit more on the risk support later on. What we've done here for you in that slide is kind of unwrap that a little bit and say there's the level of need, but then what's our public service response to that? And clearly CAMS is a major part of that story, but also you think about our public health nurses, our early health services, Kooth that I mentioned earlier, obviously 111. There's the single point of access, that's what SPA stands for in CAMS, giving advice and support across the system to children, families and professionals working with children. So we've got that kind of tiered model, if you like, in terms of making sure we've got a comprehensive service offer for children and families at the point of need. Next slide, please. What we've been doing recently is a bit of work around what we're calling pathway analysis, because I think the general sense is we've got a really good set of service, got an outstanding CAM service, really, really strong and embedded across the system. We've got a lot of good services, a really good, strong social work offer, a really good, strong early help offer in the city, all providing good services for children and families. What we're less convinced about is the join up between those services. In other words, the pathway that families, children take across that system. So we've launched a bit of work that Sonia and colleagues have been very closely involved in. We've had a system-wide piece of work on our pathway analysis to understand the journey that children take, because we're not totally convinced that it's seamless, put it that way. So if you just go to the next slide, I'm not expecting you to be able to read this slide, but that is an example of a pathway. That particular one is looking at the pathway around our secondary age children. And if you go to the next slide, you'll see another bit of pathway work. What that shows is sometimes children and families they kind of loop back round, and the kind of concept of no wrong door is not quite a living reality for children and families in Portsmouth. So when they land in a service, they get an excellent service. How they get there can be a bit random. So we've got to really improve that in the city. I think we've done it in all sorts of other arenas. I think the social and emotional mental health arena is kind of next on our list, to make sure that we're targeting and meeting the need of the right children, the right families at the right point. Next slide, please. Just the last bit from me before Sonia turns to the work at our higher tiers. We're also very keen, and Andrew keen on the line, it's probably getting bored of me saying this, is when we talk about workforce development and developing practice around social, emotional, mental health, often the language in the NHS goes back to how do we recruit more CAMS, CAMS workers, how do we retain them and how do we train them? For us in Portsmouth, we think much more broadly around that. A lot of people come into contact with children who are in mental health distress. They don't necessarily require a CAM service, but actually we can skill up and support a range of other professionals in schools, in early year settings, in public health services, in safeguarding services, to be able to meet the need around emotional distress and emotional well-being for children. Again, I'll draw that parallel with safeguarding. Everybody knows that safeguarding is their business, and we've developed skills in safeguarding over the years. I think we've removed the fear of holding risk around safeguarding over the last sort of decade and a half. We're not quite there with SCMH. We still have a lot of professionals that get very nervous around getting it wrong for children in mental health, which is why they always want a CAMS worker. We talk a lot about team around the worker. How do we get workers sitting alongside and working alongside other professionals around various agendas, and pretty much everybody wants a CAMS worker next to them to make sure they don't get it wrong. How do we kind of build the skills, the knowledge, the confidence and the competencies of a much wider set of people to be able to meet the mental health distress and mental health needs of children across the 0 to 19 pathway? So we're doing quite a bit of work on what does the workforce development look like across the system and what's the place of CAMS in this. And the next slide, please, Daniela. So if I hand to Sonia, who will then focus much more on the complex cases for the next couple of slides, and then happy to take questions. Sonia, over to you.
Okay. So the next part of this presentation is on managing complex cases and how we do that in partnership to manage the Tier 4 admissions and try and reduce the need for young people to go into a Tier 4 placement. We have a CAMS liaison service which started at the Queen Alexandra Hospital in Portsmouth in April 2020. Some challenges to that due to COVID, but we did stand up the best offer we could, seeing some people in the community, seeing young people who might need a hospital bed whilst we're assessing them in the hospital. As a piece of that work, we have developed operational meetings, and that really is with all of the partners who are involved. So that does include social care, the police, mental health liaisons, SCAS, and all partners really who are involved in young people going into hospital being discharged. And you'll see under the high intensity user part that I've named some of the partners that we're working with. And the purpose of that is to improve the pathways, to enable the pathways to be fluid for people in and out of the hospital, and to try and reduce admissions. We've been able to look at case studies as part of that, to look at what we're doing well and where we need to improve, so that again we can have improved outcomes for the young people who present in the emergency department. As part of that work, and because we are linking in with the mental health liaison team who are based at the hospital, we do have a shared space with them, and we're doing some very good joined up working, and we've joined the high intensity user group that they run, and again you'll see the range of partners who are attending that. We've included No Limits there, which is a counselling service which has come for winter pressure money, and they're also helping with discharge from the emergency department, doing social prescribing and doing some excellent work around, again, refocusing young people so that they don't need a Tier 4 admission, and also discharging people back to CAMS services. So we link in very closely with Hampshire CAMS as we're seeing people from across the area. We've linked also with Chichester CAMS and Southampton as well for people who've presented in the emergency department. The high intensity user group have developed a care plan, and again that's for all of the partners listed there to use, so that if a young person is a frequent attender in the department, there's a care plan on the Oceana system at PHT that everybody can see. And again, we'll continue to develop that work, as it is obviously a new service development for us. The provider collaborative, again, this is led by Sussex Partnership, and Hampshire CAMS are overseeing this. We are part of the provider collaborative, and again, it's about partners working together to reduce admissions. There's clinical activity panels that take place. Again, that's attended by a wide range of partners from across Dorset, inpatient, consultants, very good attendance from Portsmouth Social Care, and there is social workers invited from across Hampshire as well. And again, that's looking at young people who are admitted, who might need to be admitted, and for discharge, and working very closely together with partners, again, for the best outcomes with young people. And that is a successful meeting in terms of attendance and thinking of the needs of young people. We have a clinical governance and operational committee as part of the provider collaborative. And again, that's to look at quality, and it's to look at any risk incidents, any complaints, any issues that occur, any of the data, and what it's telling us in terms of young people who've been admitted to hospital, how long admissions take, how long the stays are, so that we can work again effectively to reduce the number of stays and days in hospital, and also for young people who do need to be admitted, that it is an accessible service, and also planning how young people would be discharged as well, and I'll come to that. John Hayward is one of the case managers that links with us locally, but there are case managers for the whole of Hampshire and for Dorset, so that they can support teams with Tier 4 admissions if they are required. And they can think with the teams about other solutions that could be in place for young people that isn't a Tier 4 admission. It's an opportunity for us to meet with John, particularly in Portsmouth, to look at emerging cases and ones that we would want to keep in the community, and use our community CAMS team to support those. We have had a history of low admissions by being able to do that as part of our team meetings with one of our teams we call the extended team, who offer longer pieces of work, and they look at emerging cases every week to try and reduce the numbers that might need a Tier 4 admission. There's also a project team meeting to look at the actual closer to home team and how that will be set up by the provider collaborative. Portsmouth and Southampton will be overseeing the Portsmouth and South East Hampshire teams, and the Southampton and South West Hampshire team. As a Solent NHS Trust, we will do that. And we are looking at how we join our pathways up as part of the provider collaborative, again, to reduce those admissions and to work with those young people in the community. Next slide, please, which is the last slide before we move to the next one. So discharge planning. So we do CPAs. We would attend those meetings for wherever young people are admitted if there is a Tier 4 admission required. And again, that enables a smooth discharge process for young people once they are discharged back to community CAMS. We're also able to link with education locally as part of those meetings to enable them to attend the CPA meetings. And the high needs support panel I've listed there is an opportunity for us to discuss with education, health and social care partners, and there's other health colleagues who attend those meetings, on who the Tier 4 admissions are, thinking about planning for those complex cases when they are discharged, and also supporting education to be able to support young people who are in the Tier 4 placement, so that we can make sure all of their needs are met. And then the CETRs are also reviewed as part of those meetings as well, to meet young people's needs. We also have links with adult mental health and adult learning disabilities. For the adult services, there's good protocols in place. We work with the EIP service, so early intervention psychosis, to look at, again, how we can support discharge or young people not being admitted to Tier 4. And we have some well-established transition protocols where adult mental health will attend team meetings locally and work with us to ensure that young people are transitioned well, particularly from our extended teams, but also if they are in a Tier 4 service. And lastly, as Hayden was saying, that we can't do everything as a CAMS service, so training is key. And we do offer training across the partnership. We have offered self-harm and anxiety training to school nurses, to the police, to social care. So again, upskill the wider workforce. As part of that, we have done some controlling worries group with schools nurses so that they can do early intervention. And we have the schools teams now who will also be looking at what kind of training aspects they can offer. There's the We Can Talk offering to the acute hospitals. And that offer is about training, and it's about raising staff awareness, knowledge, skills and confidence in terms of the children and young people that they see. And we will be doing a project with the acute hospital to put a quality improvement plan in place and project to support the training that the staff have received, and again, promote good outcomes for young people. We have some joint training planned for AMH and 111, and we are looking at some training which is going to be offered by HEE for a DBT intervention for young people that's very helpful and evidence-based around self-harm. And we are looking at whether we can do some of that joint training with 111 for our newer staff and also to support their staff. And we are also currently offering training and consultation to 111 on the cases that present, again, to reduce admission to Tier 4, but also direct people away from the acute hospital if possible. And that's the end of our slides. So thank you for listening.
Thank you, Sonia. Is there any observations or questions? I'm not sure how the agenda's going, so Olivia, back to you, but really happy to kind of answer any questions between myself and Sonia if there are any.
Oh, thank you, Hayden. Sorry, I was still on mute. I think there's a couple of questions that you've answered in the chat. Marie, did you want to come in?
Thanks, Olivia. I just wondered whether the care plans that Sonia was talking about are personalised, and if you've used a personalised care and support planning approach. I know that in our team we did some work with colleagues on the Thrive model, aligning our personalised care model with theirs, and talking about personalised care and support planning and personal health budgets or integrated budgets as well. So it's really good to hear you talking about it, actually. It's nice when somebody other than me raises this. And I think it's really positive to be thinking about social prescribing in this context as well.
Yeah, absolutely. Yeah.
We can help, make those links with families and communities in terms of looking at the assets that people can
absolutely
on locally. I think it's a really powerful message.
Yeah, couldn't agree more, Marie, about social prescribing. Yeah, absolutely. Yeah, Sonia, do you want to kind of pick up the point about personalised planning?
Yes. So in terms of the care planning, all young people who present in our emergency department would receive a risk assessment plan. But again, in terms of the high intensity user group, it was felt that an overall plan for individual young people, so personalising it so that all services, and they may be picked up by ourselves or by 111 or come into the acute hospital before we arrive, that everybody could see it, and the police a high level care plan that we're all using for that individual to support what their needs might be. And again, we've uploaded that, as I say, to the acute hospital trusts for those individuals so that those care plans can be shared more widely to support the needs of young people that are discussed in the group, so that we can think about how best we support them as a range of services and partners together.
The other just two bits worth mentioning around the kind of psychiatric liaison bit is one of our colleagues couldn't join us today because he's off on a meeting talking about the responsible clinician role, which is a complexity within the system that we haven't quite worked through yet. And the other thing is the role of youth workers deployed by the voluntary sector partner No Limits, who are much more lively in Southampton than they are in Portsmouth, but they've been certainly the feedback from the hospital that we've had is by placing youth work capacity around that function alongside CAMS professionals, that's proved to be really, really effective and really popular. So we've secured an additional year's funding for that, but we've got a little bit more work to do to mainstream that. Hi, Marie.
Hello, sorry, I just to follow up also, I was wondering if there was some crossover with this group with section 117 eligible people. So just raising, you're probably aware, but for other people in the meeting who might not be aware, there is a right to have a personal health budget or an integrated personal budget for people who are eligible for support under section 117. So I wondered if that was something that had been considered, or if if it's something that the personalised care team in the South East can help with.
I think in terms of some of that work would come out through our high needs support panel. So when we're looking at the needs of young people and looking at discharge, there is elements of that could be considered in our core CAMs, but quite often they are considered as part of the high needs support panel as well, and looking at the wider range of needs of young people around personalised budgets, and it's looked at as part of that process.
Right, thank you.
Thank you. Any other questions for Sonia and Aidan?
I have a question, if I may jump in. Really interesting, thanks, and fascinating to hear about how services are joined up and working around young people, but also supporting other services. So nationally, I understand that there's quite a low proportion of autistic females, particularly in CAMS, who are identified and supported in the community. So I think it's around 30 to 40% of community cases are girls, compared to around 70% of admissions being CAMS females. So I just wondered if your interventions have supported any shift in those proportions.
I think in terms of that, I mean, we are doing a wider piece of work in the city to look at ND and how we manage that, and there is some work on a profiling tool to look at managing diagnosis. And when we're looking at neurodiversity, so we are looking broadly at the range of presentations that young people would present with. There's some training that's taking place. We're again working with partners across the city to implement that and to look at the needs of young people. And I think in terms of our interventions, we would tailor them to the presentations that present in the emergency department, so that is picked up. Sometimes there are young people who haven't been diagnosed. That is an issue, and trying to make adjustments to individualised care based on the presentation that the young person has. Sometimes we have been asked to do further assessment of young people who've presented to see if a diagnosis would support further intervention from that, and we are seeing a bit more of that with some of the young people who presented in our CAMS liaison service.
Yeah, Jill, I think it's a really important question. Yeah, the ND profile, I think Asher's on the call as well. So myself, Asher and Sonia have been working with education psychology colleagues and other colleagues in the city around the neurodiversity profiling, which is we've trained 130 professionals across the city already around how do we, at an early point, identify neurodivergent children. I think your point about gender is a really, really interesting one, and I think it is about, certainly, I mean, Asher can talk more knowledgeably about the training than I do because she delivers it, but I think there is absolutely a point about how do we ensure that we are identifying at an early point neurodiversity regardless of gender. Yeah, I think that's a really interesting point.
Just to thank you, and just to add, Dr. Ruth Moyes has done some research which has recently been shared on this, and she suggests that we need to change the flag, so that particularly autistic girls, we don't always spot them until they're and beyond, and so yeah, there's something around what we're looking for and what support we have in place at that point.
Yes.
Just really adding to that point, Jill. In terms of the question you were asking, the number of young people being recognised being on the spectrum, especially females, and their representation in inpatient units being higher, has that been reduced? From Portsmouth point of view, I think I can talk from Portsmouth point of view because I know the other services, I can't speak about them. But from our service, the number of admissions we have had of young people who are on the spectrum, especially female, is far less compared to many of the other services, partly because the young people who have presented not just in crisis and with self-harming behaviors, there's been a lot more assessment and psychoeducation with families, working with the families in understanding what the needs are, psychoeducation with the other departments, other agencies, especially education and social care, in order to meet their needs out in the community rather than actually them having to go into hospitals. The only places where I've seen probably the admission rate increase is the ones with the eating disorder presentation and have then been found to be on the spectrum. So those are the young people who have had probably a bigger representation compared to the ones in with self-harm.
Okay, thank you very much. I think there were a couple of really good points that one that you made, Sonia, that and Marie, that I didn't bring into my introduction, which was actually the admission avoidance and everything being done to maintain people in the community and in their familiar settings as much as possible. And thanks, Marie, for reminding us of not just the principles of personalised care, but also the ability to draw on some of the personal health budgets as tools again to help us support people in the community. And then it's the second time this week, the point about neurodiversity and girls in particular, and how many of the assessments have been designed around male presentation of autism, and therefore it's more difficult sometimes for girls to get the right diagnostic or to get through the pathway as simply as it is for boys. So I think, Sarah, were you going to take us through the next, unless there are any other questions, through the next section and the discussion points?
I was, Olivia. Thank you very much. And thanks for setting the scene so well. And thank you very much, Hayden and Sonia and other colleagues, about picking up those points really about quality and patient experience and personalisation and partnership really. So my colleague Daniela Ciccuni and I, picking up from what Olivia said about the work we've been doing across various forums in the Southeast with all of the systems and the regional team. We picked up from discussions at the UEC mental health group that meets every month and the task and finish group that Olivia's been chairing on delayed discharges. We picked up some challenges and some really strong examples in every system, very practical and very workable, and actually in many cases very innovative solutions, sorry everyone, in terms of how you're addressing these issues. And what we wanted to do with the next couple of slides is just pick those points up and then throw it out a bit for some discussion to see if you think that we're reflecting back to you well what you are telling us. So we know that there's some challenges, particularly working across NHS and independent sector providers in terms of sharing both, patient and professional risks across organisations and how that translates into shared care agreements or service level agreements, and in terms of the out-of-area placements, the continuity of care principles that Olivia referred to earlier. And obviously we're aware there are information governance issues there as well in terms of confidentiality agreements and information sharing agreements, and obviously access to NHSnet, for example. So we know that there's been some really good work done in every system regarding specifically within adult inpatient environments and older adult environments, responsive work from day one through the multidisciplinary team to identify potential barriers to admission, and also work to build trust across and between teams to deliver genuinely joined up, integrated, seamless care, and therefore really robust care packages in the community. That one team, one dream approach across health and social care. And obviously, as we've said just now, in relation, for example, to social prescribing, the voluntary and community sector as well, for example. And obviously, how does IG enable that? We know we're thinking about culture change, a horrible expression, everyone, but obviously involves thinking outside the box. We want to be very patient-centred, very solution-focused, as we said earlier. We want to think about using investment in ways, for example, that maybe we've not done before. And there have been lots of good examples of that. And actually, as Hayden said, we're kind of using the same words. How is this everyone's business? This is a critical issue. It's a really, really serious and important issue. And how are we joining up on this and making this everyone's business from day one? And perhaps in addition to that, how has COVID-19 changed the way we work in I hate to say this word, but in a positive way, but in a way that we may want to carry on, may take something forward from the learning of COVID-19, I think is how we're saying it to each other within our team. So how are we enabling staff, and I'm thinking in particular about the bed managers, and in the meeting that Olivia's chaired, it's been so humbling and it's been so impressive to talk to the bed managers and hear the things that are happening, that people are doing. But how are we thinking about those services in each system that are in the community, those services that are available in reach into people's homes, for example, floating support, supported accommodation, general needs housing. How are those services being picked up and monitored in terms of what do we know about what voids there are available, for example? So not just our own bed states within the independent sector for hospital beds and the NHS sector as well, but actually what else is available and how are we utilising that knowledge to best effect? Again, what information technology enablers are there? For example, as I mentioned before, NHS Net, but actually thinking much broader in terms of simple telehealth as well. Spoken about pooled budgets and funding, and I've spoken also about how we map that capacity within the community across health and social care providers and housing sectors, and actually how we stimulate the market, how we implement commissioning changes. And also there's been some really good examples which I think many of you may want to come up and offer us when we go over to discussion about home adaptations, repairs, making accommodations safe and habitable, because obviously as we've reflected, there's an issue about making sure that our patients are able to live in and maintain a habitable home, and the impact of that on their mental health. So next slide, if that's okay, Daniela. So finally, we know there are some other challenges which are around the impact of the surge that we're seeing, both in terms of volume and acuity, how that's impacting on our acute and community hospitals, as Olivia said, and we've been doing some work with systems around 12-hour breaches in A&E departments and the reasons for those. So whether that be about lack of beds or lack of amps, transport issues, transporting patients to beds when we find those available, and accessing Section 12 approved doctors. And again, we know that there's some really good practice there, which you'll no doubt want to talk about more when we come to discussion. But for example, many systems seem to be utilising the Section 12 approved doctor app, and we know that systems are developing their own escalation processes and procedures with the acutes, and setting up, in some cases, regular weekly meeting with the acute hospitals to talk about the impact of patients within those environments and how that's resolved in terms of systems and processes and on a case-by-case basis as well. We know there's lots of challenges regarding staffing, and obviously much work going on with HEE regarding this at the moment, and every system developing their workforce plan. And we know that every area is thinking about innovative roles such as physician's assistants and apprentice nurses. I referred to acuity and complexity concerns, and again we've heard how you're developing pathways in the community, particularly regarding EUPD and more generally regarding how crisis alternative funding is being utilised across many cohorts of patients. And there's work ongoing via the UVC group, thinking about how we optimise clinical pathways, and again, how we're thinking beyond health and social care with the voluntary and community sector too, and using the services that are out there to support crisis prevention, admission avoidance, as Olivia said, but also, relapse prevention and support development of early warning plans. And as our colleague said earlier, that's quite critical to Section 117 planning and PHBs. We need to think innovatively how PHBs can come in there. And then again, the broader point about system restoration and recovery and for the region as a whole, what might we want to take forward? Has there been any helpful learning from our experience so far with the pandemic in terms of how we're going to restore and recover? And in particular, what is the local data and business intelligence telling systems in the region as a whole. And we've heard some good examples in the EUC group about how colleagues are using the BI Power tool. So I think if Daniela goes on to the next slide, I'll just go through that before we then perhaps go into any discussion points or questions or observations anyone wants to raise. So, as we've said, many very effective examples in terms of community support, accommodation, step up, step down, as both as discharge to assess or emission avoidance. And that includes those opportunities to look at the wider determinants of mental health difficulties and enhance and support quality of life. Some really good news around accommodation models, though we have heard about challenges from the supporting people, funding not being there anymore as well. And again, as I've said, maybe we need to think about how we're stimulating the market there, but actually how we're working across health and social care and the independent sector in those settings. So, for example, how does crisis resolution home treatment reach into these environments to prevent hospitalisation and to continue support post-discharge where that's required? Doing things differently with budgets, as we've said. And one really great example that we heard from Berkshire in particular, but also other systems where is, for example, how funding has been utilised to employ welfare rights workers to provide targeted support for people across the acute pathway to access benefits, because obviously not having money, not having food, not being able to pay your bills is a critical crisis for anybody, and is particularly traumatic and damaging for people who have mental health difficulties who may be in a mental health crisis. And lots of good examples regarding how that's worked really well, supporting patients to get access to benefit and actually to access even PIP, for example, and look at PIP appeals. And obviously also those support access to those services that support patients to and service users to access employment and employment support. And also examples across the acute pathway of how systems are using social workers, employing social care staff from within NHS Trust sometimes at particular points of the pathway to support the whole patient flow agenda and make sure there's timely assessment. And that, as I said, includes the welfare rights workers, the social workers, but also recovery workers, for example. So obviously we need to think about how all of that's aligned with the community mental health framework and the transformation agenda, and for both community mental health care and also crisis transformation, and that's all age obviously, and to think also in particular about the NHS plan within the context of therapeutic inpatient beds and how we develop and support that agenda, developing nice compliant care pathways across community and inpatients. And a final point there is just obviously not to forget about all people, and I'm not saying that anyone does, but I think that's a key point of learning, I think, for me in particular, how we're supporting and advancing the older people's mental health agenda across both inpatient, community and crisis, and thinking sometimes about the extreme delays that older people experience when they need to leave hospital. So I think that's the final slide on this point before we move on to out of area placements and the work that we've done there. Are there any questions? Oh, sorry, I think I missed. No, that's it. I think that's the slide. So is there any observations or comments anyone would like to make before we move on to out of area placements? And if not, I'll just go on to out of area placements if that's okay, Daniela. So, I can see Lila's got her hand raised. Did you want to come in, Lila?
Just one observation, Sarah, really. As you can see, I'm a bit long in the tooth. That actually, quite a lot of what's now innovative practice was stuff that was in place years ago. So I think we are probably seeing, a turn of the dial back to recovery workers, models like that. They used to be in place 20, 30 years ago, which is quite interesting. Youth services that Hayden mentioned earlier, of course, most places have disappeared, and now trying to put back in place again. So yeah, so just sort of slightly depressing, really. I think quite a lot of good stuff that did happen. The Supporting Housing Fund disappeared. That was really very innovative for its time, and has caused some housing issues that we're seeing now. And I don't think there's any neat solutions to some of those issues. So I think we probably shouldn't kid ourselves that all this is brand new. That I think we've seen some of these issues before, and we probably just need to take a step further to think even further outside the box, how we personalise and make services, probably before hospitalisation, more adaptable to individuals. I think individuals' needs, and how certainly what I'm seeing is we're not quite reacting fast enough. We're waiting a bit too slow, so the crisis happen and then we start reacting rather than a much early intervention.
That's really helpful, Lila, and I agree, obviously. I think there's an awful lot of learning for us to build on and move forward from, isn't there, both from his interventions that have, and initiatives that have occurred historically, but now I think in particular for systems in terms of both learning from winter pressures funding and discharge planning funding as well. And I must be honest, I've been really encouraged by what we've been hearing in the forums where we've been having these detailed discussions, but that's really helpful. So then I think it's out of area placements next, is it, Daniela? Do you just want to bring up, and obviously Olivia's reminded us really helpfully of the importance of this agenda and giving us an example, I think, which focuses on the quality and the human aspect and the very personal experience, which I think is a really important reminder. So obviously it's a key quality issue as well as a performance one in terms of achieving 0 out of area placements. We've implemented continuity of care principles in the region, working with acute leads. And that's obviously as per the guidance in the documentation, which Daniela has put on a slide for us. And we've done that working with the national team. So obviously, we're now getting local reporting in terms of appropriate and inappropriate out of area placements. And obviously that needs to be reflected in terms of the national reporting. So that needs to be aligned with the reporting from systems that goes in to the centre. We thought, as part of that, and again, thinking about how we have worked during the pandemic, we've been linking in with the independent sector and the NHS, having those discussions and thinking about how both NHS and independent sector work together as part of whole system. And critical to those continuity of care principles is how we enrich into those hospital environments, so that acute overspill, PICU, but obviously other beds as well, such as rehabilitation and EUPD, for example, are part of that whole system of care, and the patient experiences that seamlessness, which is really important. And the impact of being placed away from home or away from your geography where that happens is minimised, is mitigated against by those principles wherever possible or as far as possible. How do we share and exchange best practice across the NHS and independent sector? I know that's something that's uppermost in everyone's minds. And obviously, key to that is how community mental health services are linking in with independent sector inpatient providers, whether that be on an individual basis, care coordinators for inpatients, but then also broader in terms of pathway design and development and improving processes, as we said earlier. Again, how do we develop those nice compliant clinical pathways together? Is there opportunities, and this is something that Olivia's mentioned at least a couple of times to me, but is there something that we can do across the region and across systems in terms of our commissioning and our contracting of those independent sector organisations that are providing acute overspill and PICU, for example, the big 5 providers, is something we can do together and collaboratively that will actually improve that commissioning process and therefore improve the quality of those placements. And again, is this something that we want to learn from in the context of what we've been through in the last year or so in terms of the pandemic, and how we've had to use those independent sector services as we've been implementing social distancing and isolating, for example, within the NHS and independent sector wards. And again, how do we support the acute and community trusts in terms of the impact of mental health patients within A&Es, but within the wards as well, is another key driver for us, and forms part of this whole discussion in terms of patient flow. So, are there any observations or points that anyone would like to come on to so far? And if not, I'll just ask Daniela to go on to the next slide. Can't see any hands raised. So here Daniela has put a slide together which clarifies the advice from the guidance and the 4 key principles which we've used to implement the continuity of care guidance locally. So obviously that's around having clear shared pathway protocols between units and organisations across independent sector and NHS and independent sector. And obviously those processes being particularly around referrals, admissions, discharge, for example. Expectations that care coordinators visit regularly, and as regularly as they would if the patient was in the local NHS hospital, and retains their critical role in supporting discharge and transition and supporting community care package design and delivery. Obviously, very robust information sharing is critical. Identify cross-system capacity, access full system clinical records, for example, CPA plans, care plans, risk assessments, that's really important as well. And obviously support for people to retain regular contact with their families, really important, as we heard Olivia say from her sharing with us at the beginning. And that's obviously families, carers and support network. And again, how can we optimise that in terms of use of technology and transport provision, for example. So unless there's any questions about out-of-area placements and the protocol, I'm just going to ask Daniela to go on to the next few slides, if that's okay, Daniela. And this is really over to Daniela, who's very helpfully pulled together some slides, everyone, on the one-day mental health bed census that occurred on the 8th of April. So a couple of weeks ago. So this is the census that occurred in the acute trusts of patients waiting for discharge to mental health hospital beds. And I'm going to ask Daniela to take over, if that's okay.
Thank you, Sarah. So I suppose the key headlines that were taken from the one-day mental health bed census is that across our region there were 256 patients either in a general and acute bed or an A&E bed at the time of the census. And how that splits down to in terms of age ranges, 62% were adult mental health patients and 38% were children and young people across the southeast. So in terms of a summary of the key findings, what the report shows is that accounts for around 0.28% of acute mental health beds, which is quite low compared to other regions. But I think where we see the biggest kind of more significant impact on our systems locally, which will not be a surprise to anybody, is in terms of length of stay. So the average wait times is not that bad when you do it comparatively across different regions, but you can see the longest reported wait time for adults was 50 days and quite significantly higher for children and young people at 112 days, sorry. So that 112-day stay probably translates to around 1 or 2 individuals waiting that length of time on average. And the methodology of the census split it into 3 different beds for children and young people that require further additional mental health support, and adults over the age of 18. So for children and young people who had the longest length of stays, we're waiting for a general adolescent bed, an adolescent LD or autism bed, or a PICU. Whereas adults, they were split into waiting for adult acute bed, older adult beds, or adult and learning disability or autism beds. So just to do that, show you comparatively what that means for us as a region. As I said, is regionally compared to others, in terms of wait times, we're okay, but our biggest probably area in terms of room for improvement would be around the length of stays for those patients. If you compare it against somewhere like North Eastern Yorkshire, it is quite significantly different, and as you can see, the significant impact, which I think we already know in particular is for our CAM services, and I could imagine that quite a few of those children and young people waiting for a CAMS tier 4 bed. So that just gives you a bit of a picture of where we're at in terms of the bed census data. And what I plan to do is produce a similar slide pack together, but it breaks it down by system and circulate that to system leaders just so that they can see the outcome of the bed census results.
Thank you, Daniela. That was great. Really helpful. Thank you. So are there any questions, anyone, either about the bed census or the out of area placements in terms of protocol and the continuity of care principles, or anything regarding the learning to date in terms of challenges in terms for discharges and best practice, and how you're all developing very innovative solutions?
Unfortunately, Debbie, there was no data specifically for older adults. When you look at the raw data, it doesn't break it down that far to be able to pick them out as a specific population group to look at from a quality perspective. But I think it's a very valid point to raise, and actually whether it could be something that's introduced next year, I can pick that up for the national team.
Thank you. Thank you.
Okay, so thanks so much to everyone. It's been really, sorry, Marie, about to move us on. Did you want to ask a question?
Sorry, Sarah, I just wanted to ask a question. This is just, apologies for my own ignorance, but what happens while people wait? How do we manage that with them, help them manage that?
In terms of waiting within the acute hospital trusts?
Yeah.
Yeah. I mean, really, that's where mental health liaison and paediatric liaison and CAMS crisis services come in, both in terms of A&E departments and the wards, obviously. So post-assessment, if patients are admitted onto the wards, mental health liaison services and other services, for example, including community eating disorder services, will in-reach into the acute wards. And actually, quite topically, we've been working with systems to develop a set of standards regarding those, regarding how that in-reach occurs, if that makes sense, which we can share with you. I'm sure there'll be colleagues from systems that will want to come in on that point, though.
I think there's an element of risk, isn't there, while people are waiting? I know from my own experience, not personally, but a friend of mine, which didn't have a very good outcome. So I just wanted to flag that, really. That, while the reason why we're looking at this problem isn't just about the numbers of the beds, and it's the impact on the people while they're waiting to get the right kind of care and support, and also just sort of I think a key thread through all of the things that we've been talking about this afternoon. I'm always thinking about personalised care and how that can act as an enabler to some of this, and where we're talking about integrating kind of teams and integrated response and delivery, then the importance of personalised care and support planning, I think, is key, because you can have those conversations with people about what matters, and it might seem to people where we're talking about very critically, ill people here, and this might seem like something that's frilly, that works around the edges of what we do, and I appreciate that, but I think it's much more, because when we're thinking about what's preventing discharge and what's blocking it, we should also factor in the fact that we're Are we listening to what's important to people and what matters to them, not just what is the matter with them, if you see what I mean? So, you know, that kind of the things that Olivia was saying right at the very beginning about the things that she brought with her to visit her friend were things that were on a personal level, what she felt would make her feel human and retain some dignity in this sort of process, which feels from a professional perspective a lot like it's kind of, we're talking about throughput, and we might miss the point that there are people involved in this process, human beings that we need to remember are human beings. But also I think from a family perspective, so somebody who is acutely unwell, and you know, in that process where they're waiting for us to find the right solution for them, as much information that can be given to that person and the family as possible. You know, we must think about that in this conversation as well. And I've got sort of, it's quite personal to me, because I know people in that situation and families were not given enough information at all really about what to do if something goes wrong when you're in that secure room and you know there's nobody about and things like that. So you know, it's really practical things like that because we might be seeing these cases day in, day out, we forget that to the person themselves and their family or the carers, the people that care about them, it's new sometimes, and it's very, very, very scary for them to be in that situation.
I agree, Marie, and that's really helpful reminder, and I think you've brought us back to the key point that, you know, Olivia focused us on at the very beginning, that it, you know, this may be about a target and it may be about numbers, but actually much more importantly it's also about people and their experience. I can see Daniela's got her hand raised. Did you want to add something, Daniela?
So I was just going to say, yeah, very well put, Marie. And I think you're right. We have to remember behind each of those numbers, there's a patient and an individual. I think when Sarah and I had a catch up with Bobby from the national team around, so how do we use this data moving forward? I think from the national team's perspective, it was about being able to engage in a conversation with acutes to see, okay, so this is kind of like a case-by-case study basis, and look at actually what happened to that individual, and are there lessons that could have been learned? Have we got the psych liaison in reach offer correct? If not, can we think about alternative models?
And sorry, Marie, if you haven't seen them yet, but we can share the standards in draft form with you straight after the meeting. But and as part of that, as part of the discussion we've been having with systems regarding developing the standards, which is about the mental health liaison offer, as Daniela said, but actually about the offer from all mental health services into the acute. Yeah. As part of that discussion, we've been having that engagement regarding what the resource might be look like, but also what training is required. Completely agree with you that for many patients in acute wards, there is really and in A&E departments, it's a quite high risk situation, and we need to be mindful of that. Yeah. I can see Asha has a hand raised. Did you want to come in, Asha?
Yeah, I just wanted to actually mention, Marie, really important points that you raise. There, at the center of this, there is a human being. It's not just a patient. It's not a number. How do you actually make sense of what's going on? Being in a hospital is, first of all, quite a scary experience, and not knowing what's waiting for you is even more scarier. And sometimes I think one of the things I keep thinking about, and what we hope to do, is that even when we don't have answers to give, how can you still contain? Because with the bed situation, it's not within our gift to give. A lot of the time we are waiting for a place to come up or a bed to become available and things. The training that Sonia was mentioning, We Can Talk, that training, I'm really hoping that that's going to bring about some change in getting staff in the acute care setting feeling that they do have the skill set to have a conversation. They don't have to shy away from having a conversation. They're not actually treating them. But having a conversation does not need that skill. You have to just be a human being to understand what they're going through. And the other thing is about helping families also understand that going into hospital, what might you expect? what is it going to look like? What might be the advantages of going into hospital? What might be the difficulties and challenges that you're going to come across? And I think I do hope that the treating teams or the community teams have some of those conversations with the patients and their families, just to keep them, prepare them for what they might be, what they're going to face later on.
Agree, and that should be an important part of care planning, shouldn't it? In terms of making sure those conversations happen and remain ongoing. I think, Lila, did you want to come in?
I just want to add to what Maria said, really. I think what we don't really articulate is that for most families and individuals, being an inpatient is actually quite a traumatic experience. You know, some people do have good experience, and actually, you know, this was the right thing for me to go through that process. But the experience of being admitted under the Mental Health Act or not Mental Health Act, you know, it leaves traumatic memories for lots of people. So when we're thinking about discharges, we're not really thinking about the experience that people have had and how traumatic it's been. So, you know, when I used to work in the community services, actually a lot of people have completely lost confidence in being back out in the community because that's what the experience had meant for them. And so when we think about discharge planning and supporting people, we're not thinking about that confidence building and how do we enable people to go back out in the community much quicker perhaps, and lending some support to those individuals to do that. Now, whether that's going back to school or some sort of day opportunities for older people or going back to work for adults, I think we need to just be, you know, a bit smarter, I think, around how we work with people. And for me, you know, when Maria talks about personalisation, that's what that is about. And how do we use personal health budgets to enable some of those things to happen much better? And I think we're a long way off from doing that, really. And I think we could probably do it quite quickly if we wanted to, if we're just a bit more relaxed around thinking outside the box and not ticking quite so many boxes and taking a few more risks.
Thanks, Laura, that's really helpful. I agree, and I think I picked up a point that I think Sonia was making earlier, that it may be that when we pick up these discussions next time, we link in with personalisation leads to see how they can help us support moving forward this agenda. I think, Asha, another point that I would just make finally, it is in terms of patients of all ages that are placed in the acute wards, a perspective I think, as you know, that we're trying to move forwards with is thinking of that opportunity, that admission as an opportunity, not necessarily to facilitate admission to either a tier 4 bed or an adult inpatient bed, although obviously that may be what happens, well, that may be what's the most appropriate thing to happen clinically, but actually, is this an opportunity to actually reset a community care package, improve it, and avoid an admission as well? And that's again where work with the mental health liaison services and the standards, I think, will come in. So I think, unless there's any more questions or points, that's been really helpful. I can see some really helpful points in the chat as well. And I thank you, Marie, for that comment regarding personalisation, the offer of help. That is really helpful, thank you. And we'll certainly take you up on that offer. I think I may be handing over to Richard now. So Richard, did you want to come back in about evaluation and Menti?
Yes, hello everybody, thank you. If I can ask everyone to go to menti.com, please. The code's on the screen, it's in the chat as well, using code 38117174. We've got 3 questions for you. We'll be holding these webinars with different areas monthly, and I'm just making sure we capture feedback from everybody to make them as good as we can for you all. So menti.com, code 38117174. 9 people have done it so far, so if you haven't done it yet, please jump in and do it. You can do it on your phone or on another screen. Okay, I'll just give that 30 more seconds. Okay, this is a free format box for you. What else would you have liked to have heard about in today's webinar? I think it gives you 3 choices or 3 boxes you can enter your comments in. I'm just going to start the countdown now. I've got a minute to go, please. Thank you. Okay, final 10 seconds if you haven't pressed the enter button yet. Thank you. And what would make future webinars more useful for you or your teams to attend? Start the countdown now. Thank you. Okay, well, thank you everybody for joining us today. Sarah, would you want to close off?
Thanks, Richard.
Thank you.
Thank you very much for that feedback and those comments, everyone. And I've noted the point about some of the detail, the good examples. We will work on that for you. I think we may have said right at the beginning, we had a couple of late cancellations. Dr. Mike Hunter's team from Sheffield were able to join us a bit at the last minute. So with their permission, we're going to share the presentation from Sheffield with you. And I think that will be helpful as well. And obviously we'll go on the website with some narrative, if that's okay. Okay, so thanks everyone so much. Hope the rest of your afternoon and your evening is as pleasant as possible, and look forward to seeing you again soon. Take care. Bye-bye. Bye.
Bye.
Thank you, everyone.
Bye. Thank you.
Thank you.